Fibrosis. In this talk, we'll overview the epidemiology, etiology, and genetics, the pathophysiology, methods for diagnosis, in general clinical features, but mostly those pertaining to lung disease, evaluation and function of lung disease in CF. So cystic fibrosis is an autosomal recessive disorder. It is inherited. It is the most common life-limiting disease in populations of Northern European descent. The gene for cystic fibrosis was located on the chromosome number 7, and it encodes for the protein called the CFTR for short, or the cystic fibrosis transmembrane conductance regulator. In Europe, or in countries in which there is newborn screening programs, the incidence is about 1 to 3,000 or 1 to 2,000 live births, depending on the country. There is an increasing diagnosis among Arab countries, but there is no newborn screening program. Among other ethnic groups, like African Americans or Asians, the incidence is significantly less. About 70,000 patients with CF are present worldwide. The structure of the CFTR protein, it's 1,480 amino acids. It expresses on the epithelial, surface epithelial cells, and it has a chloride channel and also functions as a regulator of other channels like the epithelium sodium channel. It regulates iron transport across the epithelial cell surface and thus maintains the normal composition and integrity of the mucosal surface and maintains epithelial surface hydration. Mutations were identified more than 2,000 mutations, but only a handful are responsible for most of the cases diagnosed. The CFTR protein, as shown in this slide, this is the cilia on the surface of the columnar epithelium of the airway. And on the surface, this is the structure of the CFTR protein. And the channel functions to transport chloride from inside the cell to the outside. When there is a problem with the CFTR protein, the sodium and the chloride will be inside the cell. They will not move to the outside, and water as well. And this will cause dehydration and a very thick mucus on the surface of the epithelial layer, and impair functions of clearance and invite infection, responsible for most of the abnormalities with cystic fibrosis. And this is a short video from the CF Foundation showing the ciliary movement and the normal mucosal surface being cleared from the airway. This is the CFTR protein, and the chloride moves freely from inside the cell to the surface. Abnormal protein or absent, there will be no chloride efflux to the surface, and this will affect the mucosa, which will become very dry, mucus very thick, very viscid, and the cilia will fail to clear it, inviting infection, inflammation, and the vicious cycle with cystic fibrosis. The CFTR protein mutations have been classified into 6 classes according to a clinical spectrum of activity. So in class 1, there will be no formation of the protein whatsoever. It's a stop codon. And these are 12% of the mutations, and they are usually designated with the letter X. Class 2 mutations, there is a problem with processing the CFTR protein, so it gets formed in the mucus, but for some reason it does not reach its destination. And this has the delta F508 mutation, which composes the majority of cases or alleles of CF patients. Class 3, there is a gating defect, so the protein on the cell surface, but there is a problem with the efflux of chloride. The class 4, there is like a broken channel, so altered conductance. And then class 6, there is a reduced number of CFTR protein. The genotype-phenotype association is usually related or associated with pancreatic dysfunction because respiratory complications have a variable correlation with the class of mutation. Classes 1 to 3 are usually associated with severe disease and severe pancreatic deficiency, but not necessarily with severe respiratory disease, usually, but not necessarily. So diagnosis of CF is done by many methods. Newborn screening in countries that implement screening is done by a heel prick test and a dry spot of blood on a Guthrie card. Usually IRT or immunoreactive trypsinogen is measured. It is a precursor of trypsin and it is increased in the blood of newborns with pancreatic disease. And in some countries, they also screen with the most frequent CFTR mutations. Sweat chloride later on in life is still considered the gold standard for diagnosis. Testing pancreatic insufficiency can be done indirectly by measuring the fecal fat content in a 72-hour collection sample, which is not usually very practical. Fecal elastase is another measure to indirectly assess pancreatic function. Direct pancreatic sampling from the GIT endoscopically is not very practical, but it is a measure of pancreatic secretions. Nasal potential difference across the epithelium is also used, not very frequently, but maybe if other tests are not conclusive. Prenatal testing is available by chorionic villus or amniotic fluid sampling, and pre-implantation diagnosis can be done with in vitro fertilization, and sometimes evidence with ultrasound can show meconium illness. These are the countries that implement screening for cystic fibrosis worldwide: North America, Latin America, Russia, most European countries, Turkey, and Australia. Sweat test was introduced in 1959, and values above 60 millimoles per liter are considered positive, where values below 30 millimoles per milliliter are considered negative, and this is a new limit. Previously it was 40, and values between 30 and 60 are intermediate. And the false positive sweat test can occur with many conditions like adrenal insufficiency, eczema, hypoparathyroidism or hypothyroidism, and malnutrition, while a false negative test result can occur with like a faulty technique of sampling, some malnutrition, edema, and some antibiotics. The criteria by the CF Foundation Consensus Panel to diagnose cystic fibrosis include one or more characteristic phenotype features consistent with CF, like chronic respiratory or GI disease or salt loss syndrome, male infertility or urogenital anomalies with absence of vas deferens, or a history in a sibling of CF or a positive newborn test for screening, plus increased sweat chloride or 2 disease-causing mutations or an abnormal nasal epithelial iron transport. The mutation analysis for cystic fibrosis, because there are so many mutations present, it is not always a definitive diagnosis. Commercial panels are available. They are covering most of the CF causing mutations, more than 80% of them. Other mutations can be identified with genetic sequencing. 2 mutations present are supportive, but not necessarily diagnostic of CF, and failure to find 2 mutations still does not exclude CF. The delta F508, which is a class 2 mutation, is the most frequent mutation identified. Presentation of CF usually focuses on respiratory, GIT, and increased sweat electrolytes. And historically, the salty kiss was a diagnostic test for cystic fibrosis. In pulmonary involvement, the lung is the primary cause of morbidity and mortality, and that's why for pulmonologists, CF is really a very, very big deal. Colonization and infection is one of the major problems, and a lot of organisms are implicated. These are the most important. And this is how the progress of pulmonary involvement, and it starts with infection, and then an inflammatory response occurs. There is airway obstruction and hyperinflation and mucus impaction, bronchial wall damage and bronchiectasis. Hemoptysis may also occur, and ending in respiratory failure, passing with pneumothorax and digital clubbing. However, CF is by far not only a respiratory disease. It can have many other organs involved, like neurologic or psychiatric problems, ototoxicity mostly from the drugs used in treatment, cardiovascular like cor pulmonale or pulmonary hypertension, pancreatic insufficiency, steatorrhea, meconium ileus in newborns, or distal intestinal obstruction syndrome in older children, liver cirrhosis with portal hypertension, splenomegaly, growth failure. Pancreatitis occurs if there is residual pancreatic secretion and deficiency of fat-soluble vitamins. Renal involvement, mostly congenital absence of the vas deferens and nephrotoxicity from the drugs. CF-related diabetes, CF-related arthritis, allergic bronchopulmonary aspergillosis, and chronic pansinusitis and otitis. Nasal polyps are also a feature for cystic fibrosis in older children and in adults more. The pancreatic insufficiency occurs because the pancreatic ducts become obstructed and inflamed from the abnormal pancreatic secretions due to the CFTR absence or malfunction. And this decreases or prevents pancreatic secretions from reaching the small intestine and causes fat malabsorption, responsible for the steatorrhea, the abdominal swelling, the bulky and foul-smelling stools, and of course, weight loss and growth failure and fat-soluble vitamin deficiencies. Pancreatic insufficiency is of course managed by pancreatic enzyme replacement therapy. And the dose is identified by kilogram or by the gram fat of intake per day. This is one of our patients, and he presented for the first time at the age of 12 months, and his weight was 3 kilograms. And this was at the age of 4 years. He was at that time on pancreatic replacement enzyme therapy. Liver disease is also a feature. There is liver cirrhosis and biliary obstruction, jaundice, and portal hypertension with splenomegaly and so forth. In CF, as we said, meconium ileus is a feature in newborn infants, and distal intestinal obstruction syndrome in older ones, and it presents as an acute abdominal pain similar to appendicitis. Rectal prolapse usually presents at a younger age group. Bacterial overgrowth can occur from the antibiotics intake or a high fat and high carbohydrate diet. Fibrosing colonopathy may occur, especially with excessive enzymatic replacement, and can cause strictures and obstruction. The uncommon presentations may be hypochloremic alkalosis or dehydration, allergic bronchopulmonary aspergillosis, anemia and hypoproteinemia, and neonatal jaundice. For pulmonary disease and cystic fibrosis, mainly we check the function by doing pulmonary function testing, either spirometry in older children or infant PFTs or other methods in the younger children. Later, we can do structural assessment by imaging, doing CT imaging, which is now more recommended than the traditional chest X-ray. Pulmonary function testing under normal conditions. This is the diagram on the left. In the middle, with moderate CF, there is air trapping, small airway obstruction with increased residual volume, and the ratio residual volume to total lung capacity would be higher. Later on, there is restrictive lung disease in addition to air trapping or small airway obstruction. So there is a marked increase of the residual volume compared to total lung capacity. These are flow volume loops showing that early in CF, we have a graph similar to asthma with obstructive airway disease. Later on, with progressive loss of lung function, we have a restrictive disease pattern. Regarding the infection, age-specific infections are usually present. So early in life in smaller children, there is an increased incidence of Staphylococcus and Haemophilus influenza. Later on in life, Pseudomonas becomes the predominant organism in adolescence or in adulthood. And this is the timeline of evolution of Pseudomonas infection. So early on, the Pseudomonas is the planktonic or the non-mucoid strain. And in this phase or early in this part, the infection is usually intermittent and can be eradicated. Later on, the Pseudomonas transfers to a mucoid phenotype with a biofilm formation. And this is a chronic type of infection, and it is almost impossible to eradicate. And the goal would be just to suppress the infection. And this graph shows the life expectancy decreasing after the development of the chronic or the mucoid strains of Pseudomonas. So the earlier this happens, the less life expectancy. The non-mucoid strains are apparent as the yellow line, and these can be eradicated. CT changes in cystic fibrosis are consistent with airway disease, so bronchial wall thickening, bronchial dilatation, atelectasis, and overinflation because of air trapping. The goals of therapy for cystic fibrosis are to prevent irreversible lung damage, reduce the infections, reduce exacerbations, improve lung functions, reduce the use of parenteral antibiotics and loss of work or school days, reduce respiratory symptoms, and overall improve the quality of life. The targets for management of pulmonary disease are physiotherapy. So primarily airway clearance is a very important topic. Bronchodilators are used, mucolytic therapy, anti-inflammatory therapy, hypertonic saline antibiotics, and not to underestimate the value of exercise. For obstruction, airway clearance using pulmozyme or Dornase alpha, hypertonic saline, and bronchodilators. For inflammation, corticosteroids and azithromycin, antibiotics for infection. Bronchodilators are important to relax airway smooth muscle and improve breathing difficulty. And the pulmozyme or Dornase alpha usually attacks the excessive neutrophil DNA that accumulates with neutrophilic inflammation in the airways. Antipseudomonal treatments mainly are aminoglycosides like inhaled tobramycin, oral azithromycin, colistin, and inhaled aztreonam. Tobramycin is available as an inhalation solution or dry powder. Aztreonam is approved for patients 6 years or older. Colistin is more available in European countries rather than the US. Hypertonic saline is given. The concept is to increase the sodium and chloride content on the surface and draw water and hydrate the airways. It has a quick and short-term effect, but it can stimulate cough in some patients. This is a short video of how CFTR modulators work. So the CFTR protein on the surface is not working. A small molecule will open the gateway, and this is an example of the ivacaftor or the potentiator for the gating defect. The CFTR modulators available now, the most recent is the last one, which is the triple therapy. It is a corrector, and potentiator. It's been approved last year for ages 12 years or older. It is suitable for delta F508 mutations. The tezacaftor, ivacaftor, or Symdeco has also a corrector and potentiator. Lumacaftor, ivacaftor has the same corrector potentiator combo, and ivacaftor was only licensed for class 3 mutations.
Professor Maggie, probably 2 minutes because we have...
Yes, I'm almost done. Okay. So the difference between corrector and potentiator is that the corrector has more channels, the potentiator has more activity, and this is the effect of the correctors improving FEV1 in CF patients. The gene replacement therapy is the anticipated cure to correct or edit the gene for causing CF, and this graph will just show how the increased survival of patients was a result of introduction of different types of treatment over time. The life expectancy in the 1950s was below 5 years. Now the Northern American registry shows more adults than children with CF reaching above 40 years. And thank